Good morning, everyone. Thank you for joining us. Welcome to Data for Impact's webinar, co-hosted by the New Partnerships Initiative, NPI EXPAND. My name is Tori Taylor. I'm the project's technical director. Next slide, please. The webinar is going to be presented in English today with closed captioning available. If you'd like to turn on English closed captions, select the live transcript CC button from your Zoom menu, please. Data for Impact, or D4I, is funded by USAID. D4I is a consortium led by the University of North Carolina at Chapel Hill in partnership with Palladium, ICF, JSI, and Tulane University. I'm going to pause there for a moment. I think we may have a few other folks just joining us. All right, thank you. D4I works to strengthen local capacity to generate and use high-quality health data for strategic decision-making about health policy and programs at the national, subnational, and community levels. The project investigates programs' effectiveness, integrates gender into all its activities, supports adaptive management, and learns from evidence. D4I draws on the technical expertise that exists in each of our partner organizations and an extensive network of local partners in USAID priority countries. Next, please. The focus of this series, as you probably know, is localization. Localizing MERL helps local actors have the resources and capacity that they need for equitable, effective, evidence-informed decision-making. Applications of this in MERL activities include local capacity strengthening activities, systems lens, engagement with diverse stakeholders, and implementing other good practices for locally led development. Today's our first webinar in the series. We'll share tools and approaches for capacity action planning, sustainability monitoring, including examining local actors' roles in complex program systems, promoting local voices using social accountability methods, which is the focus of today's webinar, and more. Follow us or sign up on our newsletter to receive information about upcoming webinars in the series. The next one will take place on February 28th at 9 a.m. Eastern Standard Time. And it's going to focus on using Sentinel indicator monitoring and network analysis to assess health program sustainability in Nigeria. Next, please. Today's webinar will give an overview of the NPI EXPAND project's social accountability work in Ethiopia and describe the community scorecard approach to improving primary health care. The webinar will outline the steps used in the community scorecard approach, give an example of its implementation by the local Ethiopian organization, ILU Women and Children Integrated Development Association, IWCIDA, describe the outcomes realized through the implementation, and talk about lessons learned. Now, it's my pleasure now to hand it over to Nasir Ali, Chief of Party for the NPI EXPAND Ethiopia project. Thank you. Over to you, Nasir.
Thank you so much, Tori, for the nice introduction. Good morning, good afternoon, everyone. Thanks for joining us. Today, I'll be presenting social accountability program in Ethiopian health system context with particular emphasis on community scorecard that was designed and endorsed by Ministry of Health Ethiopia, aiming at improving family planning, maternal, newborn, and child health service outcomes. So I'm Chief of Party for NPI EXPAND project, new partnerships initiative project funded by USAID. Next slide, please. So as I've just said, NPI EXPAND, or new partnerships initiative, EXPAND is a 5-year cooperative agreement funded by USAID. The project is being implemented in 10 different countries. NPI EXPAND supports local partners in India, Pakistan, and countries from East Africa, and some other countries from West Africa, as you can see on the slide. In addition, the project is supporting local implementing partners in Brazil and Guatemala. Significant proportion, like 60% of NPI EXPAND funds directly goes to local implementing partner, and the project adopts grant provision or issuing grants to local implementing partners and providing technical and organizational capacity to local implementing partners to enable them implementing family planning, maternal, newborn, child health, and COVID-19 mitigation and education, particularly social accountability in Ethiopian healthcare system. Next slide, please. So NEPI expand global result frameworks. The goal of the project is increasing availability and utilization of health services. The project has three result areas as organizational sustainability. Currently in Ethiopia, we are supporting over seven local implementing partners, building their organizational and technical capacity to efficiently and effectively implement social accountability to improve maternal, newborn, and child health outcomes in Ethiopia. Uh, and in line with the second result area, which is increased utilization of products and the information, NPI Expand Ethiopia is implementing community scorecard. That's one of social accountability tool to improve accessibility, utilization, and quality of family planning and maternal, newborn, and child health. We are also scaling up innovative social accountability approach. So in summary, NPI Expand Ethiopia follows or aligns with the global NPI Expand result framework. Next slide, please. So as I've just said, in Ethiopia, we are aiming at increasing availability and utilization of high quality family planning, maternal, newborn, and child health services through application of community scorecard. Evidences have shown that proper implementation of community scorecard resulted in improvement in FP MNCH service outcomes. Our approach is we've provide grants to 7 local implementing partners and provide tailored technical and organizational capacity strengthening to facilitate and strengthening the leadership capacity of local implementing partners to efficiently implement the project. In Ethiopia, we are supporting 5 regions. We NPI Expand focus remote and underserved parts of the community. The biggest regions, including Amhara, Sidama, Southwest, South Ethiopia regions are being supported by the project with particular emphasis to economically disadvantaged women, girls, and children newborns. Next slide, please. So this is a standard definition. You can find a different definition for social accountability, but we've adopted social accountability definition of the World Bank because the project called ESAP, Ethiopian Social Accountability Program, supported by World Bank, has been implemented in Ethiopia for more than a decade. So Ministry of Health Ethiopia, supported by implementing partners like NPI Expand, adopted a community scorecard from the experience of ESAP program. So currently Ministry endorsed community scorecard, which is a local governance tool for monitoring service, empowering communities and improving accountability of the health system by enabling communities to measure health facility performance and to provide feedback. So currently NPI Expand is supporting 5 regions, 24 districts, 224 villages, and 46 health facilities, empowering and building the capacity of community structures to hold the service provider accountable and to identify a major health service gaps and develop a joint action plan with the community and implement and follow up the implementation of those joint action plans and improve its contribution in the improvement of family planning, maternal, newborn, and child health outcomes. Next slide, please. So, as I've said, Ministry of Health views community engagement as a critical vehicle. As you may know, Ministry of Health Ethiopia has been implementing consecutive 5 years strategic plan to improve the health of Ethiopian citizens. So in addition, during the last national assessment of Ethiopia's health extension program, the research or the assessment revealed that facilities with highest performance consistently demonstrate stronger community engagement than the lower performing ones. And also, if there is no strong community, were no strong community level coordination mechanisms that effectively engage community platforms to drive improvements in Ethiopia. That was the finding of the National Health Extension Program assessment. In addition, the research have found out that the health sector doesn't routinely engage the communities in health and service decision making. Rather, they treat the communities as a passive recipient of health service, which resulted in low community trust, insufficient community awareness, and limited understanding and accountability between the service providers and the right holders. Next slide, please. In addition, when we see the regional context is similar with the national report resulted from the assessment done. In Southwest, one of the regions that NPI EXPAND is supporting, we've conducted baseline assessment and learned that Wereda or district health system in the primary health care system, staff, leadership, and management didn't know, they don't have clear understanding of the community scorecard implementation. And also there were no established community structure who are responsible for facilitating the scoring session. And also there is no women development army structures who are expected to provide or score the quality, accessibility, and utilization of health facility health services provided by local health facilities. Like 72% of the primary healthcare unit didn't conduct community scorecard in Southwest Ethiopia region. So some of the challenges that resulted in non-implementation of the community scorecard is the staff doesn't have clear knowledge and skills on community scorecard implementation, where less, inadequate leadership attention, and also lack of materials and a transportation issue to take people to the Kabbalah level where the real community scorecard is implemented and the like. The other issue is the data quality issue. We've learned that in the regions and in national health system, the data quality issue were one of the big issues that we understood during the startup of the NPI EXPAND project. Next slide, please. So after having all this contextual baseline assessment, we decided to implement NPI EXPAND supported by USAID, started implementing community scorecard for the last couple of years through our local implementing partners using the local governance tool community scorecard. Just to give you high-level overview of community scorecard theory of change, we've adopted this theory of change from the previous primary healthcare transformation projects supported by USAID. Just to give you some highlights on the theory of change, if we properly implement community scorecard, which brings the community members, service providers, and local government together to identify underlying barriers and facilitate to access, utilization, and the provision of quality service, and to generate, implement, and monitor solution, it would end up with improvement in governance. So the governance improvement includes women and community members are empowered. They would exercise their rights, entitlements, and able to hold the service provider accountable. And also the other governance outcome is the platform for negotiation or discussion between the right holders and the service bearers, the health facility, the health service providers, and the community will be expanded, and the health workers will be empowered because they will be trained, they will gain knowledge, and they would learn what the community's perception about their service. So if the governance outcome increased, the health behavior and service delivery outcomes would improve, which includes improved health behaviors, increased utilization and satisfaction with service system, and institutionalization change will be improved. All this would contribute to reduction in maternal and neonatal mortality. As you know, Ethiopia is one of the countries with the highest maternal mortality, like 420 maternal days per 100,000 live births. So if we properly implement the community scorecard and following the 6 cyclic steps that I will come to it would really contribute to the reduction in maternal mortality. Next slide, please. So just to take you through some of the 6 step community scorecard cycle, as I've just said, community scorecard follows a 6 cyclic steps, which includes understanding of community perception. Basically, this is understanding how community evaluate or perceives the quality, equity of health service provided by the local health service provider. The second step is establishing community groups, which we call it client council, who are responsible for facilitating the whole scoring process, compiling reports, and provide the report to the local health facility management and the governing boards to take an action. The third step is facilitating community scorecard, the scoring session by itself. The fourth step is facility visit. This is more of verification visit. It is a process through which the client councils who facilitated the scoring process go to the health facility and triangulate and verify the community perception and what is really on the ground, and to get the full insight of the community perception and the service providers. The fifth step is conducting a bigger platform that brings the community, that we call this public conference, the service providers, local governance, to listen to the reports about the service provided by the local health service providers, the facilities, and then to develop an action plan on the 6 steps. So this is a 6 cyclic step. I will take you through each step briefly. Next slide, please. So the first step is understanding community perception. Ministry of Health had conducted a rapid assessment to understand community perception about the quality, equity of primary health care services, focuses on the 6 indicators. Those indicators are directly aligned with maternal and child health service. The first indicator is the availability of motivated, caring, and compassionate health providers at health facility. So the community believes or perceives if there are compassionate health providers in the facility, the service is believed to be quality and equitably accessing by the all communities, by the community members. The second one is waiting time. If there is a less waiting time to get service from the health facilities, they believe that is quality and equitable. The third one is availability of medicines, diagnostic services, and medical supplies, infrastructure, availability of management of ambulance, and cleanliness and safety of health facility. The 6 priority indicators that will be scored, measured by community structures, facilitated by the client councils. The scorers are the 1 to 30 women. We call them Women Development Army, 1 to 30 people. They are 30 women led by one early adopter woman who understands the health service quality, accessibility better than or the local community. So she will be responsible to lead the 30 groups. So she will support those groups to improve their behavior, skills, and knowledge about health service. So they are the one believed to be having good understanding of the quality of health services. That's why they are the one who will going to raise up their cards and score based on these indicators. Taking you to step 2, next slide, please. So just to brief you about the role of different health system structure, the role of Ministry of Health, develop and share indicators. We have already supported Ministry to identify those key indicators that I've just presented in the slide. The role of local implementing partners, they are responsible to strengthen the capacity of primary healthcare system, community structures, monitor the implementation of the scoring process. The health workers are responsible to mobilize the community, provide information. the healthcare facilities have to improve their, the quality of service they are provided based on the feedback from the community. The district health service are also responsible to oversee the district health system as a whole. Next slide, please. Step 2 is establishment of client council. As you can see from the slide, there are 7 to 10 members in this group, which includes women association, youth association, people with disability, underserved group, individual influential person are the part of this client council. The role and the responsibility of these councils are, conducting, facilitating the scoring system, compiling reporters, and provide and present the reporters to the health facility management leadership to take an action, because all the community scorecard cycle is more of led by the community structure by itself, because the ministry wants us to make free of this bias or any kind of influence from the local health system. This is a transparent and independent scoring process, evaluating and monitoring the quality and equity service provided by the local health facilities. So this is a step 2. You can see on the photos that was when USAID country mission went to the field and visited the scoring process. Next slide, please. Step 3 is the actual scoring session. The community structures, the Women Development Army would be informed, would be oriented on each indicator. What does indicator mean? How to score, how to raise up their cards. And there is a facilitation guide which helps the client council, the facilitators responsible to facilitate the scoring process. Scoring is done in every kabale. Every quarter. Ethiopia has like 15,000 villages. When I say kabale, so all these villages should score or provide feedback to the quality of health service they are being received from the local health facilities in a measurable way, so that leadership of the ministry regional health bureau could take an action to improve the health outcomes. So the rating process is we provide, or NPI EXPAND, and the system provides 3 cards to the each scorer. That's a green, yellow, and red card. Red stands for 1, medium yellow, and green 3. Next slide, please. So these are the indicators, just to give you some highlights. For example, the indicator 1 is motivated, caring, and compassionate health workers. The criteria for scoring is if the respectful, if the health workers are respectful for their patient, showing compassion and provide full information, if they are motivated. So the scorers, the Women Development Army or 1 to 3 group, facilitated by the client council, scores, they can raise up the red card if they believe, if they perceive the health facility fulfills only 1 criteria from these 4 options, they would raise the red card, medium, high. And finally, the client council, consolidate, summarize the scores from out of 100%. For example, availability of drugs and diagnostic services and supplies, availability of essential drugs. If the community members, the scorers perceive the drugs are available, they would raise like high, or if they meet only 2 criteria out of the 3 here, they would raise their cards accordingly. Next slide, please. These are the remaining, the other 3 indicators. As I've said, with Ministry of Health in collaboration with USAID and NPI EXPAND identified these 6 indicators. For example, availability of and management of ambulance. So if the ambulance is available all time, if the availability of ambulance services and responsiveness, because if the driver are responsive in the midnight while the laboring mother calls them for at any time, the ambulance driver should be alert and respond to the request. If the driver takes them to the health facility to have safe childbirth, so they can rate accordingly. So the client council provides orientation to the scorers on each indicator, so they can efficiently and reliably raise their cards accordingly. Next slide, please. Step 4. So after the scoring process, the client council visits the primary healthcare facilities, that is the local public health centers, and shares the aggregated score results, and inquired about the community, communicate about community scores and comments, and also they triangulate whether the community perception with what is actually on the ground, if the maternity waiting room, if the delivery room are clean, if the health facility have all the infrastructures, electricity, water, if the ambulance is properly serving, or if the ambulance is not functional, if the diagnostic services, medicines, essential medicines and supplies are available or not. Based on all the indicators, they would verify a community perception with what is actually on the ground. Next slide, please. So step 5 is after all the verification, the scoring process, the next step is organizing town hall meeting. So as I've said, the score were provided by 1 to 30 or 30 women representing their Kabyle, but this town hall meeting provides an opportunity to the general community, if they have any feedback other than the one provided by their representatives. Most of the time, from experience, from what we are observing on the ground, the community really raises so many important critical gaps of the health service, even other than the measurable score results provided by the 1 to 30 group. They raise so many issues. It would really give an opportunity for the right holders to hold the service provider accountable. On this, platform, community platform, local government representatives, the health facility board of directors, management team, health facility staff will participate on this public forum and hear and listen to what community in general is saying about their services. Lastly, the step 6, next. Okay, so some of the community issues raised during the community concerns during the general public forum, community mostly in the 5 implementing regions that NPI EXPAND is supporting: poor infrastructure, about lack of electricity and water. Whenever the laboring mother comes to a health facility during the midnight, they were really suffering from lack of electricity, water to get quality services, inadequate supplies. Most of the time, the patients are told to go out and go to the private pharmacy and look for the drugs they want. Unhygienic health facilities in some areas, poor ambulance management, poor health worker competence. Even the community have the capacity even to assess the skill of health professional, midwiferys and other health professionals, long waiting time to get health service. At the beginning of the project, when we started a couple of years before, these are some of the concerns raised by the community in the different community scorecard sessions that NPI EXPAND through its grantees has been supporting. Next slide, please. So during the community platform, the local government representatives, health facility leaders, and community members by themselves, they jointly sit together and plan for improvements. So they plan for improving health workers' behavior, renovation of the health facilities, and also emphasis to the health commodities supply chain of drugs, laboratory reagents, ambulance maintenance and ambulance management, renovation of maternity waiting areas, improve cleanness of the and safety of the health facilities, and reducing waste. The waiting time has been prioritized as an action plan. Next slide, please. So finally, after identifying all these problems, community members, the local government, and the health facility leaders sit together and develop an action plan. And they set the timeline for each action plan. The responsible person will going to be responsible to remove or solve the problems will be developed, and that action plan will be followed by the whole health system, regional, zonal, district, and even the health facility, including the community representative, will follow whether the implementation of the action plan identified during the last quarter community scorecard implementation process would be followed by all those responsible person. And this cycle would continue throughout the process. Next slide. So by this, we wrap up with the community scorecard cycle, the 6 steps. Now I invite my colleague from local implementing partner, Gada Tolera. He's a Chief Executive Officer, as well as a Program Director for ILU Women and Children Integrated Development Association. He will tell us about the actual results they have found during the implementation of the scoring processes. Over to you, Gada.
Thank you, Nasir. Given the long process of community scorecard implementation, we have come to achieve these results in the southwestern Ethiopia People's Region. The graph you are observing entails about the key community scorecard indicators, which Nasir was presenting earlier. This was the progressive, changes we have able to achieve in the course of the project period. If you see the first indicator, the caring, respectful, compassionate care, from the baseline, which was taken in December 2022, and if you see by 2023, there is a measurable difference between the citizen satisfaction in the caring, respectful, and compassionate care from the service providers. The second indicator, waiting time for provision of health services. From the baseline, there is a measurable difference also in achievement of this indicator as well. From the baseline, which was as low as 53% to 67%. Availability of medicines, diagnostic services, and medical supplies. From the baseline, as you observe, there is a measurable difference in this regard as well. Infrastructure, it was as low as 51%. The citizen satisfaction was as low as 51%, but significantly improved to 70% satisfaction-wise. Overall, from the baseline, which before the project implementation to June 2023, there was an improvement from 51% to 68%. This was the result was achieved after a rigorous implementation of the community scorecard and different community, facilitations in collaboration with all the stakeholders at the very community level, as well as zonal, warada, and regional level implementing partners, active engagement. Next slide, please. This slide is handled by Nasir. Over to you, Nasir.
Thank you so much, Gada, for taking us through the actual measurable results of the community scorecard provided. That's really the actual reflection of the community. NPI EXPAND is supporting very remote, for your information, Southwest Ethiopia is recently established region, administrative region in Ethiopia, which is bordering some of the zones and villages bordering Kenya and some South Sudan. So there is huge infrastructure, health workers problem, and high maternal mortality. So through our implementing partner, ILU Women and Children Integrated Development Association, the baseline was, as you've seen, is below 50%. That's real community perception. But through the last couple of years, our grantees have been providing, capacity strengthening support to the primary healthcare system. establishing community structure, empowering community to exercise their rights and entitlements, and able to score the quality of health service provided by the local health facilities. So after those investment, at least we are now observing improvements, but there are still critical issues that the Ministry of Health and development partners, including the society, the community by itself, and civil society organizations should support the community to get quality health services going forward. So there are also some service delivery improvements that we've observed through the course of implementation of NPI EXPAND. Health service providers are demonstrating improved commitment. There were really some administrative actions in 224 villages about the behavior of health workers providers. If some of them were not properly behaving towards the community, and we've supported the local even judiciary system to take appropriate action on the behavior of the health facility, ambulance health workers, ambulance drivers. So there is really a good improvement. Some of them were misbehaving because of lack of knowledge, lack of leadership support, lack of misunderstanding. So we even provided in some areas about the ethical service provision. We've been doing a lot in improving their behavior. Communities have generated, what we've learned from the implementation of this project is communities are not only expecting something, they are not only exercising their rights, they are also key resources for improving health services. They've contributed millions of Ethiopian birr mobilized in support the health facility, and like fencing the health facility, doing some road infrastructure, establishing cleanness of the health facility, supporting how to clean the health facilities. They've been doing a lot. The communities are also resources. Regional health bureaus, Warada Health, and the leadership made some decisions to mobilize funding to purchase medicines. Electricity and water supply improved. Cleanliness and sanitation of campaigns have been conducted in all the health facilities that NPI EXPAND is supporting in the last couple of years. So demonstrated a big improvement in contributing to the reduction of maternal and child mortality. Next slide, please. So I now hand over to Gada as well to take us through some of the practical improvements that have been observed, demonstrated in the region that Gada and his team has been supporting, that is ILU Women and Children Integrated Development Session. Over to you, Gada, to take us quickly through your slides.
Thank you, Nasir. These are the tangible, results which we able to achieve in the course of the project period, because in different, areas of the project operational area, there were no health facilities, even leave alone, accessing the service. The locality, there were localities which had no any health facilities, and the health centers were constructed with mobilization of the community and the pertinent actors, private as well as local government actors. This was one of the community concern, whereby during the community scorecard raised as an issue where there is no facility to access the service, leave alone the quality, accessing the quality service. There was no facility where the community can access some sort of health services. So the community and local government constructed a health center where there was no health center, based on community priority, which was come to discussion on board during the community scorecard implementation. The other challenge, bottleneck to health services raised during the community scorecard implementation, was roads connecting health center to the community are poor. As a result, the ambulance service cannot be accessed by many citizens living in the locality. So this issue was raised to pertinent, government actors, as well as even the community has also some contribution in the maintenance or renovation of the road. Accordingly, as you may see on the photo, the road was maintained to serve the purpose of reaching out the unreached community by the ambulance services. The other issue which was raised during the community scorecard implementation was the untidiness of the health facility, which was voiced to be improved. To this end, bi-weekly cleaning and safe health facility campaign was conducted at respective primary healthcare units, so that the cleanliness and the safety of the health facilities were improved. Next slide, please. Yeah, this is a key family planning, reproductive, maternal, and new child health services indicators, which was in addition to community scorecard indicators. These are the RMNCH indicators which we have focused and took the baseline before entry of the project. The baseline was taken, and then against the baseline we have measured the service progress during the project implementation. This is, I'm presenting to you one of the health facility which we have been supporting by the community scorecard implementation. The health facility was called Achida Health Center, which is located in Konta zone of Southwest Ethiopia People's Region. If you see the first indicator, contraceptive acceptance rate, it was as low as the satisfaction of the community. The service reached by the community was only 45% before the project implementation, but improved to 76% by fiscal year 23 in the fourth quarter of the NPI EXPAND project implementation. Antenatal care, it was still below 50%, but improved to 73% by the fourth quarter of the NPI EXPAND project implementation. Deliveries attended by skilled health professionals, it was very low before the project implementation. After the community scorecard implementation, it was improved to 55%, but the figure also still indicates there is a long way to go to address the unmet needs. Postnatal care visit within 7 days of delivery, it was as low as 43%, but improved to 56%, but it is still the figure, indicates there is a long way to go still to address the demand of the community. Children fully immunized by first birthday, it was 67% uptake, but by fourth quarter of the NPI EXPAND project implementation, the community scorecard implementation, it was improved to 100%. Next slide, please. Yeah, overall, in the Southwest Ethiopia People's Region, there were a lot of challenge in implementing the community scorecard in different facilities of found in the region. The first one is a budget constraint preventing action plans to implement to address the gaps. There were multiple gaps addressed, identified by the Health Development Army, as Nashir was mentioning, in the course of the community scorecard discussion sessions. There were lots of issues aired, and the major taken responsibilities is an assisted officials plan to address the gaps in the next budget cycle. If the budget plan for the fiscal year is under cannot address all the demands voiced by the community, we were insisting, the government officials to plan to address the gap of the community, which remain unaddressed in the upcoming, budget year. The other is the stakeholders buy-in and commitment in different facilities, in different localities where we have been conducting the community scorecard. We have faced, we can say resistance and being, busy with another government duties, and some service providers commitment problem were sensed. In order to address this challenge, we were actively engaging the Warada and health level meeting so that the buy-ins could be issued. We have been monthly holding health extension workers review meeting at the primary healthcare unit and quarterly holding Warada level health officials, project implementation progress review meeting. So we were, pushing, facilitating their buy-in. So, frequently and periodically having these officials, Warada officials and service providers on board. The other challenge we have faced in the course of implementing the community scorecard at community level is a lack of medical supplies, particularly family planning commodities, which the citizens, frequently raise in different community scorecard sessions. So what we did was providing support to health facilities and Waradas to address the supplies gap through different mechanisms that we have created in the course of frequently bringing them to discussions popping out from the community scorecard implementation. The other is a delay in salary payment for health center staff, comprised their ability and dedication, compromise to serve the patients. This was, the country context whereby the region unable to pay the salary of the health service providers. And what we did was, contract relevant, we have approached relevant authorities to address the salary payment issue, and it was addressed no matter how, as quickly as it was taught. Topographic challenge for transportation, the region comprised of localities which are very at very distant location from the health facilities. So we have to reach out to these communities to hold the community scorecard discussions and mobilize different community activities. We have explored other feasible transportation methods to facilitate the scoring activities at the community level. And our community level practitioners and project managers, field level quality assurance officers have been even going on foot to reach out to the community where there is no different means of transportation that helps them to reach out to those communities. Finally, the continual national campaign had an impact on our daily operations, whereby our plans are pushed forward because of overlapping with government campaigns. To overcome this, there were cases, incidents where we supported even the national campaign, whereby we mobilized our team at field level to support the government partners and reschedule our programs to overcome the challenge. Next slide, please.
Thank you so much, Gada, for your presentation. Guys, there are some good questions coming up. I would like to, finalize the next couple of slides briefly. So, as Gada mentioned, Ethiopian health system has been experiencing challenges as any other developing countries. So the leadership and lack of understanding of the community concern and reluctant to address those issues, lack of resource, topography, limited budgets to address community issues, and some ongoing conflicts in some parts of the country has been challenge on NPI EXPAND project, but we are, designing adaptive solutions to those challenges, like providing the project provides motorbike and ongoing advocacy of health issue to the leadership, and providing in discussion with the decision makers, mobilizing resources to address those resource gaps, and continuous monitoring of staff safety was some of the adaptive managements that we've been employing. Next slide, please. So lesson learned, we've learned a lot from the community scorecard implementation. First, we've learned accountability can be measured quantitatively. That's been a buzzword, accountability, as you know, in the health system particularly, but we can now measure accountability in quantitatively. The other, we've learned community scorecard improves community trust. When we started the implementation of the project, the community has been saying that health center, and they didn't even own, in saying, that's a health center which doesn't belong to us. But these days, we start to hear the community say, our health center, so those kind of unintended results were observed. Community scorecard empowers community to exercise their rights, entitlements. They've got power, understanding, knowledge, skills about their rights, and hold the service provider accountable. Community scorecard contributed to mobilization of resources from the community, from relevant implementing partners. Currently, the health facilities showed by you, by my colleague from ILU Women and Children Integrated Development Session, it was supported by some other implementing partners, development partners working in the region. So it's really contribute to resource mobilization. It contributes to advocacy of citizens' rights, strengthening health service providers' interest, capacity. So those are some of the lessons we learned. And I thank you for your attention. Over to you, Lisa, to take us through Q&A and other slides. Over.
Hi there. Thank you. That was such a wonderful presentation, both of you. So can you go to the next slide, Samantha? Yeah, so before we get into the Q&A, I just wanted to mention that we do have a series of webinars coming on the theme of lessons in localizations, experiences and perspectives from the NPI EXPAND project. We're going to be covering co-creation, local partner capacity assessments, as specific as indirect cost recovery, resource mobilization, and financial sustainability, gender mainstreaming and integration, and overall capacity strengthening approaches and measurements. And I think Samantha has put a link there where you can register for the next event and also sign up for email updates. So I know we just have a little bit of time. I'm going to facilitate the Q&A. So when Nasir and Geta, when you're responding, if you can just be brief so that we can try to get to a few questions. So the first one is from Charles Kalinzi, and he is interested in understanding if you considered using any weighting criteria in any of the variables. He asks, are the factors all the same in terms of beneficiary community? I thought that was a really great question. So over to you.
Yes, absolutely. That's interesting questions. While we were identifying those criteria that was directed to improving family planning, maternal, newborn, and child health service outcomes, we didn't weight that. We gave all the indicators equal weights. As you've said, improving health workers' behavior is not as equal as, improving the infrastructure which might need millions of dollars to improve road construction and others. I totally agree with your point. It should be weighted. You can simply improve through mentoring, coaching the behavior, and provide medicine, ambulance, could be managed within at least fair amount of resources, but it shouldn't be the same in terms of weight. But we didn't utilize that weighted average for each indicator. We will consider it. Thank you, Charles, for your important question.
Okay, there's a question here from Raz Stevenson. The question is around, it seems there are different types of actions. Most involve increased budget allocation, and the data seem to show some plateauing of the improvements beyond the baseline. So the question is, what is the process of engaging decision makers to increase budgets and allocate providers where needed?
Yeah, that's another important question. The budget resource scarcity is everywhere. Some of the reasons for this limited budget allocation is lack of misunderstanding. There is a gap and there is poor relationship between service providers and decision makers and the right holders as a community. What we were doing was bringing some decision makers and right holders together and discuss. And really, we've noticed and gained good improvement in budget allocation. Some of the decision makers, the finance personnel, the big people saying, oh, we didn't know that community concern. We can manage, we can reshuffle some of our budget and prioritizing health issues. That was one of the benefits that we've got from the implementation of community scorecard, build this relationship, brings community concern to the decision makers. It was really because the budget management in Ethiopian health system, in the Ethiopian government system is handled by Ministry of Finance. So unless there is a bridge, unless we bridge the community and the health system and the finance team, they might not understand the real concern. That's really contributed relationship building, monitoring, and organizing such community government platforms contributed to the allocation of budget for health service improvement. Thank you, over.
Great, thank you. And then there's a second question, a few additional questions around provider behavior. Measurement by a team of empowered women may change the action. Are there additional data collected anonymously from clients? And then how do you change behavior without alienating the providers who are likely working under duress with lacking of inputs? And then how is the provider voice also included? And then related to that, what specific behaviors are being addressed? And are they linked to the WHO framework for RMNCH? So a few related questions there.
Yeah, that's fair. Another important question is about people's behavior in when they interact with their the patients. Honestly speaking, some of the some of the behaviors that was mentioned by the community members are even they are not good. Some of the communication they had flagged during the public conference, some of they are really not good to discuss at this kind of platform, because they were really mistreated, they were not loved, they were discriminated. Some of them were pulled, some of them were and harassed by health professionals. That was really sad to hear, because of their personality, because of their economic status, because of their hygienic whatever. That was really a sad scenario that we've landed, but what we did was, the community has got, whenever we bring the community perceptions, what the community said to the health facilities, and tell to the health providers, the leadership, the management, and boards in front of them, so they can listen to what they have said. The communities are very smart. They know, even they can measure the competence, the skills of providers. They mentioned some, Mr. Somebody is not doing well. He didn't know how to, how to handle the newborn, how to provide quality immunization, a kind of that. So even we brought all those information to the health facility. Even they name you by your name. They know who is working in that facility. That really gives an opportunity to everybody in the platform understand what the community can really understand. So those are the way we preach community issues to the health facility workers. They know. So they cannot cover up, or they cannot hide somewhere. They know everybody, because they are all supporting the, yeah. So what we did was, we provide intensive coaching, mentoring, psychosocial support to the health professionals, telling them we are, professional ethics. They are our community, they are our mothers. further continuous support were provided to the health providers. If they keep doing that wrong behavior, demonstrate that wrong behavior, some of them were fired, some of them were some administrative decisions were made. For example, even the ambulance drivers, even the the gatekeepers, sometimes when mother comes to the health facility in the midnight, some of the misbehaving gatekeepers didn't allow mothers to get in and automatically fired. So these are some of the administrative decisions that we are supporting the health system to take to reduce that kind of behavior. Honestly speaking, I'm not aware of the WHO framework. Please, I will learn more on that. Thank you for mentioning that, Stephen, and others. Gada, I'm sorry for taking the driving seat. You can simply jump in and provide.
I think there's one last question maybe that we can ask Geda, which is from Tibebu Alemayehu, which is around, could you comment on how you implemented the improvements based on the feedback from the community scorecard? How is that accountability reinforced? And then also, is this approach aligned with other similar local and national initiatives, such as the ALMA scorecard process? So how is there accountability, for these improvements being made, and is it similar to other local and national initiatives? Geda.
Definitely, the accountability is enforced at different, echelons of the implementation process, whereby the community itself, hold the service providers, the duty bearers accountable for all the, deviations of services from the standard. There is a standard of service in respective health facilities, whereby the community assess the quality of the service in terms of quantity, in terms of the quality. These all things are measured. Then the citizens, the users of basic service, the citizens will hold the service providers accountable through implementation of the community scorecard. This model works where during the interface meeting, whereby the town hall meetings are conducted, all the issues raised, the community priorities raised are presented to the service providers. Then they will be held accountable. That time, the service providers will admit and jointly plan a joint action plan, prepare a joint action plan to solve all the service gaps, the bottlenecks, happening to the service provision and blocking the quality service for the community. To be very honest with you, I don't know the ALMA model. Perhaps if he unpacks, or if Nasser has got that point very well, he can address. Thank you.
Nasir, anything to add on the similarities with the ALMA?
I'm not sure about the ALMAs, but I have gotten a chance to work with the ALMA team, and even recently I've met a couple of team members from the ALMA. We've been working with them. We've worked on different models like managerial accountability, community scorecard. I haven't heard about the ALMA model. It could be, we can read further on that and address. But to tell you about the accountability, we need to work hard in Ethiopian health system to hold the, the service provider accountable. This is a beginning, long way to go. It's not all done. Ethiopia has like 15,000 villages and like over 1,000 goredas and 3,000 health facilities who should be accountable for their service, for what they are doing. So we need to, having this an opportunity to call upon all development partners and the expertise attending this webinar to contribute and show up for that support. Thank you.
So I think I'll do one last question because I acknowledge that we're over time, and then the team, if you're available, Nasir and Geta, maybe you can write up some brief responses to the other great questions that we've gotten. We can send it out when we send the slides and the link, because we have gotten a lot of really rich questions. But there's a few questions here around sustainability and how to institutionalize this process. So one person has asked, how do you encourage the scorecard to continue in communities that may not be seeing as many quick solutions and big jumps in the increases due to structural issues, et cetera? And others are saying, how can it be institutionalized and operated as sustainably and low cost as possible? How can we be thinking about sustaining this in the long term?
Yeah, that's very important question. Unfortunately, the project is winding up after a couple of months. NPI Expand Ethiopia will end. So we are working on the transition and sustainability plan. So we've been, from the beginning, we've been involving the community structures, building the capacity, supporting them, and also supporting the health system to own and institutionalize. We developed guideline and we supported Ministry of Health Ethiopia to try, and we provided TOT and capacity strengthening to the health system actors. We engaged even other relevant stakeholders to understand the accountability model and supporting the community ongoing going forward and eventually to sustainably implement these community scorecards. The other is the community structures who are scoring as well as the facilitator are volunteers. We don't pay anything because it's not allowed by the government to pay them, and to make sure it is sustainable after the project phase out. So all this, sustainability approach have been doing from the beginning. We, from even the ministry started implementation of community like 5 years before, but it won't, work it because, some of them didn't implement the full cycle, the 60 step. Some of the health facilities, insert the scoring results by its own. They provide reports to the Ministry of Health, their own voice, not community voice, their own rates. Most of them, if you see DHIS2, District Health Information System, that's a reporting channel that the ministry is using, almost all of the health centers have 99% score. That's really very embarrassing, not acceptable, because the community is not satisfied by 99% level. When we, even in the world we are currently supporting, at the beginning, they have been reporting 99% in all the indicators. When we came in and start the steps and train them, they say, as a first point, they said, no, we don't like this report. We have been reporting 99%. We've been celebrating all those. We've received so many, trophies by our 99 score from the ministry, but in reality, it was like less than 50% community satisfaction. That was a big problem. So we've been supporting the system to be honest, to be transparent, to be accountable, even for the reports that we are providing. Those are some of the initiatives that we are adopting in ensuring sustainability, but it is really a great concern. We are involving ministry, regional health bureau, zonal health department, committee members, even in our closeout plan that we have already developed, drafted. So we are engaging in this sustainability. It is really a big issue. The other key issue is also the community fatigue. If we keep scoring without responding, that's the key problem, that we've been observing. So we've been trying to, this stage as a beginning, we try to strengthen community trust, building relationship. The health center director, public health center director, go to the community saying, I'm speaking with the electric facility or electricity authority or roads authority to construct. I'm discussing with the Ministry of Health to get more supplies. Please, but I did from what I have, I've been conducting, I've worked on this, I've improved this. So it's about trust, this community fatigue is, if they keep waiting, nothing is coming. At the end of the day, they might not come to your community platform discussion, whatever. So we're working on that, building trust. Even in some areas, the community starts to say, oh, our health center have been doing a lot by what they have. But the electricity is about electric authority. The medical issue is about Ethiopian pharmaceutical supply chain. And they are understanding the capacity as the authority of the health facility and keep supporting their own health facility. Those are some of the issues, but the community fatigue and sustainability remains, some alarming issues. So we will keep supporting. Fortunately, this program will be implemented by another upcoming USAID-funded project, implemented by some other or implement donors. So we are trying to transit those kind of initiative, lesson learned and challenges to the upcoming project, who is already hit the ground running at this time. Over to you.
Wonderful. Great. Thank you. It does sound like sustainability is really fundamental, and you all have been thinking about it and are documenting it so that you can really ensure that that happens to the best of your abilities. So I just wanted to thank you, Nasir, and thank you, Geta, so much for this presentation. I was already familiar with the project, but learned so much more even today. Again, we will be sending out the slides, the notes, and we can answer some of these questions. So, we will definitely look at them and send them out. And thank you all for staying late. Really appreciate it. And thank you for being such an engaged audience and raising such wonderful questions. And yeah, hope to see you on future webinars as well. Have a great day, everybody.
Great. Thanks for the opportunity.
Thank you.
Great.
Thank you.